يا عصام، ازي حضرتك؟
ازيك يا فندم
ازي حضرتك؟
وهطلع عشان ما اعطلكمش. اتفضل يا فندم.
الله يخليك، شكرا يا دكتور عصام، شكرا.
عفوا يا باشا، عفوا يا باشا.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. يسعدني ويسرني اليوم أن أكون في معية الأستاذ الدكتور محمد أحمد، وهو من الداعمين كل أنواع الدعم العلمي والمعنوي والمادي للجمعية المصرية للتخدير وطب الحالات الحرجة بالمنوفية. كل أنواع الدعم أستاذ الدكتور محمد أحمد بيعملها لنا، وأنا علشان ما ضيعش وقت حضرته أحب أعرفكم إن الدكتور محمد ما عندوش أي عقبات في إنه يتفضل بوقته وبجهده وبماله في أي وقت. مجرد إن أنا بس بتصل بيه بقول له يا فندم إحنا عايزين محاضرة، عايزاها إمتى؟ فيا رب اللهم اخلفه عليه بركة في المال والأهل والولد، ويجازيه عنا كل خير يا رب على المجهود والدعم النفسي والدعم المعنوي والدعم المادي اللي هو بيقدمه لنا. وان شاء الله هو بيقول لنا موضوع النهارده هو تشالنجينج جدا جدا. كلنا اول لما بنقول بس معلش العيان مركب في قلبه ومش عارف ايه ومنظم ضربات ومش عارف ايه، بنقف ونتخشب في مكاننا دقيقه. وانا هتصرف ازاي النهارده؟ ان شاء الله دكتور محمد هيقول لنا هنتصرف ازاي. اهلا وسهلا بحضرتك يا دكتور محمد، ان شاء الله حضرتك ده وقتك. اتفضل يا فندم، اتفضل.
شكرا جزيلا دكتورة صفاء، ربنا يكرمك ويجازيكي كل خير على المجهود اللي حضرتك بتبذليه ويجعله في ميزان حسنات حضرتك. أنا دلوقتي عملت شيرنج للسكرين، واضحة عند حضرتك؟
تمام حضرتك.
تمام. بسم الله الرحمن الرحيم. Today we will talk about the perioperative management of patients with CIED, cardiac implantable electronic devices. In this presentation, we will start with a brief introduction about the CIED, and then what is the problem of the presence of the CIED during the perioperative area, how the electromagnetic field produced by the thermi and other machines used during the perioperative area can affect the function of these cardiac devices, how to prepare this patient and how to assess this patient preoperatively, how to prepare yourself and your patient, and how to manage the case intraoperatively, and what is the postoperative management of such patients. And then we will discuss what to do if you have an emergency situation, an emergency procedure for a patient with this cardiac device. And before the take-home message, we have a case scenario. We will discuss this case together. We have to know that in USA, only in USA, there is more than 3,300,000 patients having these devices implanted. So it is not uncommon to face a patient coming to the OR who have this device. And the number is increasing in our countries nowadays, and is expected to increase more and more in the coming years. So we have to know how to deal with these patients in the perioperative area. The cardiac implantable electronic devices, or CIED, it includes a lot of devices. The most important for us is the implantable cardioverter defibrillator, or ICD, the permanent pacemaker, the cardiac resynchronization therapy device, and there are another two devices that are inserted in the patient only to monitor and to record the arrhythmias. These are like memory card inserted subcutaneously in the patient. The patient will press on this device to record the arrhythmia. Once the patient feels that the arrhythmia will start, he press these devices to record the arrhythmia, and later on the cardiologist can analyze the arrhythmias from this device and can diagnose the kind of arrhythmia. These two devices, which is implantable cardiac monitor and the implantable loop recorder, have no effect or have no any does not need any precaution during the procedure, except that it is better to send the patient to the cardiologist to analyze the period before the operation, because the interference from the diastole may record the arrhythmia, may be recorded by these devices as arrhythmias by mistake. But it does not lead to any harmful effect if it is present during the surgery. So the main focus will be on the ICD, on the permanent pacemaker, and on the CRT. The pacemaker is a device that is inserted to treat symptomatic severe bradycardia, either due to complete heart block or sick sinus syndrome. The permanent and most effective treatment of such cases is the pacemaker, permanent pacemaker. Nowadays, with the advance of technology, we have kinds of pacemaker that are called rate responsiveness pacemakers. These pacemakers increase the pacing rate during the activity and during exercise, and during sleep and during rest, it decreases the pacing rate. As we all know, the pacemaker modes are classified according to letter coding system. The most important are the first three letters. The first letter, it denotes the chamber of the heart that is paced. The second letter, it denotes the chamber of the heart that is sensed by the pacemaker. And the third letter refers to the response of the pacemaker for sensing the electrical activity of the heart. The pacemaker can respond either by inhibition of pacing or by stimulating pacing the heart after it senses the electrical activity of the heart. We classify also the pacemakers into two types: synchronous and asynchronous pacing. Synchronous pacing, there is a sort of interaction and cooperation between the pacemaker and the native electrical activity of the heart. So the pacemaker will sense the electrical activity produced by the heart, and according to that, it will either inhibit pacing or stimulate pacing. If the response of the pacemaker is by inhibition, so it will stop pacing and it will allow the electrical activity initiated by the heart to propagate through the conducting system and to depolarize and stimulate the remaining cardiac chambers. In the pacing or triggering response, if the pacemaker, once it senses the electrical activity produced by the atrium, for example, it will pace the ventricle. This happens in case of AV block. If the pacemaker will sense the electrical activity from the atrium, it will pace the ventricle to contract. There is no contradiction between the pacing of the pacemaker in this mode and the electrical activity of the heart. The other kind of pacing, or the other mode of pacing, is the asynchronous pacing. In the asynchronous pacing, the pacemaker will ignore, will neglect any electrical activity initiated from the cardiac muscles. So it will pace the heart at a regular fixed pacing rate whatever the heart is, there is any electrical activity initiated from the heart or not. And even if there is any electrical activity produced from outside sources like the electromagnetic or the cautery machine during the operation, this mode also, it neglects any electrical interference coming from the heart or coming from outside the heart. The second type of device is the ICD. ICD is the implantable cardioverter defibrillator. This is a device inserted in those patients who have recurrent ventricular dysrhythmias, recurrent VTAC or recurrent VF. This device will sense this arrhythmia, and once the device diagnoses that this is ventricular arrhythmias, it will deliver shocks to abort this arrhythmia. So it is a kind of internal defibrillation to abort the ventricular arrhythmias in those patients who has recurrent ventricular arrhythmias. The third device is the CRT, the cardiac resynchronization therapy device. This is a device which is called biventricular pacing. In this device, there is pacing of both ventricles of the heart. It leads to synchronous contraction of right and left ventricle at the same time. It is indicated in those patients with severely impaired myocardial function, in those patients who have asynchronous contraction of the right and left ventricle due to impaired cardiac function or due to bundle branch block. So the impulse does not reach to the right and left ventricle at the same time, and the response of the right and left ventricle by contraction does not occur at the same time. There is asynchronous contraction of the right and left ventricle. By applying and inserting this cardiac resynchronization treatment device, it will lead to synchronous contraction of both right and left ventricle, and it improves the myocardial function. Most of the recent ICD and CRT contain both function, pacing and defibrillation function at the same time. What is the problem during the perioperative period if we have a patient with CIAD? The problem comes from the electromagnetic field produced by a lot of machines used during the perioperative period. This, the most important source of electromagnetic interference in the perioperative period is the diathermy machine, the diathermy used during surgery. The nearer the site of use of the diathermy to the device, the stronger will be the electromagnetic interference with the device. If the surgeon will use the monopolar cautery, it has a stronger field than the bipolar cautery. In the monopolar, if the surgeon will use cutting cauterization, it has a stronger electromagnetic field than the coagulation mode of the diathermy. So our main issue during the surgery is the use of the diathermy in these patients who are having these kind of devices. Other sources include the transcutaneous electric nerve stimulator, the electroconvulsive therapy, radiotherapy, MRI, and lithotripsy. All these are sources for electromagnetic interference with the function of the cardiac devices. What is the problem of this electromagnetic interference? The problem is that the device will interpret these waves coming from the diathermy as if it is native electrical waves produced by the heart. So it will diagnose, or better to say, it will misdiagnose these waves from the diathermy as if it is cardiac activity. So if the patient has ICD, cardiac defibrillator, cardioverter defibrillator. The waves coming from the diathermy will be misdiagnosed as ventricular arrhythmias. And the response of the ICD will be by delivering defibrillation shock to the heart. So now the patient got a defibrillation shock unindicated in a normally contracting heart. This defibrillation shock may produce pain, which is the least side effect, or it may by itself produce VF or VTAC or cardiac arrest to the patient. If the patient has a pacemaker, the pacemaker will misinterpret these electromagnetic waves as if it is cardiac activity. So it will sense, the pacemaker will sense these electromagnetic interference waves as initial electrical or native electrical activity from the heart. The response of the pacemaker in this situation will be according to the mode of pacing. If the response of the pacemaker is by pacing or triggering, so the pacemaker will pace the ventricle but at a higher rate, because the rate and the frequency of the electromagnetic waves coming from the diathermy is fast. So the response will be faster pacing of the ventricle. If the mode of the pacemaker is by inhibition, if the response of the pacemaker is inhibition of pacing, once it will sense electrical activity of the cardiac muscles, when we use a coronary machine, the response of the pacemaker is by inhibition pacing. So it will inhibit pacing the heart, while the patient initially depending on the pacemaker. And during the use of machine, in this case, the initial or the baseline cardiac pathology will be unmasked. So we will find that the heart is contracting in the rate of the complete heart block, 35-40 per minute. We will find that there is a drop of the cardiac output, drop of the blood pressure during the use of the SME. So this is the problem of the presence of a coronary machine during the need by the cardiac devices during surgery. Other rare effect of these machines on the cardiac devices, if the surgeon will apply the coronary machine directly on the generator of the device, it may cause direct damage of the device, which is a rare complication. Sometimes a strong electromagnetic field nearby the cardiac device will produce total device failure. The device will not sense, will not pace, will not deliver any defibrillation shock to the heart. Another also rare complication of the electromagnetic interference is activation of what is called power on reset, something that resembles what is in our mobile phone when you resume or reset to the factory setting. So the pacemaker will be resetted to the manufacturer setting. But sometimes the manufacturer settings are not suitable for the patient, because it may be the presetting of the machine, the default presetting of the machine may be pacing at a rate of, for example, 50 or 55 beat per minute, which is very low rate. It will produce low cardiac output during the perioperative period. As we know, there may be blood loss, there may be some hypovolemia. The heart may need to compensate by increasing the heart rate to increase the cardiac output to compensate for this hypovolemia and the bleeding. This compensation is not available if and is not possible if the default setting of the pacemaker is at a low rate. But fortunately, alhamdulillah, most of the current cardiac devices has advanced technologies that enable it to differentiate between the electromagnetic interference come from other sources and the electrical activity of the heart. But we have to know the response and the effect of the electromagnetic field on these devices and how to manage. Another type of interference, which is a mechanical interference. By mechanical interference, we mean that there is mechanical stimulation or mechanical displacement of the sensors, of the sensing lead of the pacemaker during either insertion of the CVP catheter or during the use of bone saw by the surgeon, or even during shivering in the post-operative period, or during occurrence of fasciculation due to the succinylsonium injection. All these movements can cause mechanical interference with the pacemaker, and it may lead to an appropriate response from the pacemaker. Now we have to know if we have a patient coming to the OR and this patient has an implanted cardiac device. How we will assess this patient? During preoperative or pre-anesthesia assessment, we have to know a lot of information about this device. What is this device? Is it ICD? Is it pacemaker? Is it CRT? And why this device was inserted? Is it due to heart block, due to sick sinus syndrome, due to impaired contractility, or due to recurrent ventricular arrhythmias? And can I continue? And also, when this device was inserted, if this device was inserted long time ago, we have to ask about the last time of interrogation of this device by the cardiology. We have to know what is the remaining battery life, because if the battery of this device is about to be consumed, it's better to change the battery of the device before the elective surgery. And where is this device inserted? Most of the cardiac devices are inserted in the left pectoral region, left subclavicular area. Rarely it is inserted in the right side, and very rare to be inserted in the abdominal wall or subcutaneously in the lateral chest wall. How can we get this information? First, from the patient, if the patient is educated enough to know this information about the devices, or sometimes the patient has, and he should have a device card, which in this device card, all information about the device are included in this card. Also, we can get the information from the cardiologist or from the CIED team who inserted the device. If we know the company, manufacturing company of the device, we can get the contact telephone number, and we can call the company. Suppose that the companies of these devices has full information about the kind of device inserted in each patient. Also, we can depend on the chest X-ray and ECG to know the information about these devices. Regarding the chest X-ray, this is the pulse generator picture of the cardiac device in the chest X-ray. In the chest X-ray, we can differentiate the three kinds of devices: the ICD, the pacemaker, and the CRT. If the patient has an ICD, we will check the leads of the device. The leads of the ICDs is of homogeneous thickness and radio opacity over the length of the lead. As we see, all the lengths of the lead have the same radio opacity and thickness. When we have these leads, especially when we know that this lead is in the right atrium, this lead is in the right ventricle, and the leads have the same thickness all over its length and the same radio opacity all over its length, this means that this is a pacemaker. When we find that there is different part of the lead which is thicker than the remaining length of the lead, and is more radio opaque than the remaining length of the lead, this is an ICD, because this thick radio opaque part of the lead, it contains the defibrillation coil. So in the chest X-ray, if we will find part of the lead thicker and more radio opaque, this means that this is an implantable cardiovector defibrillator. And as we said, most of the ICDs has two functions, defibrillation and pacing of the heart. If we have a third lead, in addition to these two leads, if we have a third lead, the third lead is a lead in passing through the coronary sinus from the right atrium to the left ventricle. So it can pace the left ventricle. So we have a pacing lead in the left ventricle, pacing lead in the right ventricle, and another lead in the right atrium. This is a biventricular pacing. This is a cardiac resynchronization device. We said that the cardiac resynchronization device, it will pace both right and left ventricle to produce synchronous contraction of the right and left ventricle at the same time and to improve the cardiac contractility. Also, most of CRTs has another function, which is inside, beside pacing of the heart, it can defibrillate the heart. This is CRT defibrillator because it has a defibrillation coil. In this chest X-ray also, we can find a CVP catheter inserted through the right subclavian vein. This is the loop recorder. The loop recorder is a device, as we said, it records the arrhythmia. It looks like a USB or a memory card inserted subcutaneously. Why I'm having this chest X-ray of loop recorder? Because it may be misdiagnosed with another kind of pacemaker, which is called leadless pacemaker. This is a more advanced pacemaker, very small pacemaker. It has no leads, and it is inserted through the femoral vein through a catheter and implanted into the right ventricle. It has very limited indications, and it paces only one chamber, which is right ventricle. This is leadless pacemaker, and this is the X-ray picture, and we have to differentiate between this leadless pacemaker X-ray and the loop recorder inserted. The ECG of the pacemaker is very important. If we have a patient with cardiac electronic devices, the pacemaker, we will find the pacing spikes. If the pacing spikes precedes or come before the B wave, this means that this patient has atrial pacing. If the pacing spike comes before the QRS complex, this means that the pacing here is ventricular pacing. If we have a pacing device before the B wave and another pacing spike before the B wave and another pacing spike before the QRS complex, this means that the patient have a dual pacemaker or atrioventricular pacemaker. It paces both the atrium and ventricle. In this ECG, we have a pacing spike before the QRS complex, But we have another complexes without pacing spike like this one, and this one. This means that the pacemaker does not pace all the cycles of the heart. It senses the electrical activity of the heart and it responses either by pacing or inhibition. It is type of synchronous pacing. If the electrical activity is enough, it will pace the heart. If the electrical activity is enough to spread through the conducting system, it may be the response may be by inhibition pacing and leaving the initial electrical activity to activate the remaining cardiac muscles. So it paces on demand. This is a demand pacing, demand ventricular pacing. Here is the ECG if we will use a diathermy during the surgery in a patient with pacemaker. Here we have spike before the B wave, another spike before the QRS complex. In the following cycle, spike before the B wave, and another spike before the QRS complex. And then once the surgeon started to use the diathermy here, the spikes and the QRS complex will disappear and the pulse oximetry wave will disappear. And if we have a wave for the invasive blood pressure monitoring, we will get shortening of the amplitude and damping of this wave, and the blood pressure will be very low during this period when the surgeon is using the diathermy, because the diathermy inhibited the pacemaker, inhibited the pacing of the device. So preoperatively, there we have to have a good communication with both the cardiologist and the surgeon. We have to supply the cardiologist with information about the procedure, where the site of the procedure, and the surgeon has to inform the cardiologist that he will use the diathermy or not. He will use bipolar or monopolar, the frequency of the usage of the diathermy in this case, and according to the knowledge given to the cardiologist, we need to know from the cardiology the type of this device. Is it pacemaker or ICD or CRT? And the pathology that led the patient to have this device, is it sick sinus syndrome, complete heart block, impaired myocardial function, or recurrent ventricular arrhythmias, and what will be the response of the heart of the patient if the device will stop working, and how to treat this device pre-operatively. Do we need to reprogram this device pre-operatively to avoid the effect of the electromagnetic waves coming from the diathermy or not? Also, we need to know from the cardiologist the response of this device if we will put a magnet on this device, as we will see in the coming slides. How to solve the problem of interference of the electromagnetic waves coming from the diathermy with the function of the cardiac device? We can solve this problem by what is called reprogramming of the device. By reprogramming, we mean that if we have a device that has the function for defibrillation of the heart, we need to stop this defibrillation function, because the device will interpret the waves coming from the diathermy as ventricular arrhythmia, and it will deliver unindicated shock to the heart. And as we said, it is very harmful to the patient. Also, if the device has synchronous pacing of the heart, we need to convert this synchronous mode into asynchronous mode, because the synchronous pacing will sense the electrical activity coming from the diathermy as if it is electrical activity coming from the heart. And as we said, it will either pace the heart at a higher rate of pacing, or it will stop pacing from the heart, and the cardiac output will be very low, and the heart rate will be very low during the period of use of the diastolic. So we need to turn the device from synchronous to asynchronous. In asynchronous mode, the device will not sense any electrical activity, either coming from the heart or coming from the diastolic, and it will ignore all external sensing, and it will pace the heart at a fixed pacing rate. If we have a patient with ICD, and we need to avoid the inappropriate movement of the patient during surgery, like if we have a patient having ICD, and this patient will do intraocular surgery. Suppose that during the intraocular surgery, while the ophthalmologist is inserting a knife inside the eye of the patient, and the patient developed VTAC or VF, and the device developed or a shock, electrical shock, to treat and about this ventricular arrhythmia. The response of the patient will be jerky movement due to the painful effect of this shock, and this jerky movement may lead to trauma and loss of the eye, because the knife of the surgeon is inside the eye. So if we have to avoid any jerky movement coming from the patient, we have to deactivate the defibrillation function of the ICD, even if there is no use of the diastolic in the surgery. If we have a device that when it is converted from the synchronous to asynchronous mode, the pacing rate will be 60 or 55, and we need the pacing rate to be higher. So by reprogramming, we can increase the pacing rate of the device. We have to deactivate any rate responsiveness of the device during the perioperative area. Reprogramming can deactivate the rate responsiveness. We said that there is some kinds of pacemakers. It increases the pacing rate during activity and exercise, and it will decrease the pacing rate during sleep and during rest. This function has to be activated in the perioperative period. How can we reprogram the CIED? We can reprogram the CIED either by using a reprogramming machine or by using a magnet. What is the difference by reprogramming through a machine or the magnet? The reprogramming machine, we have to call the CIED team, the cardiologist who is dealing with the cardiac devices, and he will bring the machine, and he will reprogram the device through this machine. But magnet, if it is available, we just need to put this magnet directly on the device. Reprogramming using the machine, it will stop the defibrillation function of the ICD. And if this ICD has a pacemaker function, it will do nothing with the pace. Reprogramming machine can convert the pacing from synchronous mode to asynchronous mode. We need the pacemaker to work asynchronously during the operation. So this can be done using the reprogramming machine. While if we will reprogram with a magnet, the magnet, when it is applied on ICD, it will stop only the defibrillation function. But the pacemaker, the magnet has no effect on the pacemaker of the ICD. It cannot turn the pacemaker of the ICD from synchronous to asynchronous. It cannot increase the pacing rate of asynchronous mode of the pacemaker of the ICD. So if we have ICD, the magnet has limited effect only on the defibrillation function of the ICD, but it do nothing with the pacemaker of the ICD. What is the case if we have an ICD, if we have a pacemaker? If we have a pacemaker, the reprogramming machine can convert the pacemaker from the synchronous mode to the asynchronous mode. And also it can increase the pacing rate. If the pacing of the pacemaker in asynchronous mode is 60, it can increase it to 80, to 90, it can increase it up to the rate that is suitable for the perioperative period. In the magnet, if we apply a magnet on a pacemaker, it will convert the mode from synchronous to asynchronous pacing, but it will not do anything with the pacing rate. If the default rate in asynchronous mode of this device is 60, it cannot increase. The magnet cannot increase the pacing rate. So the magnet has a limited effect on the device if it is compared with reprogramming with a reprogramming machine. It may be an advantage that the magnet, we don't need the CIED team. We don't need the cardiologist to reprogram the device. Once we will put the magnet on the device, the reprogramming will begin. But not all the devices can respond to the magnet, because some devices, during the setting of this device, the effect of magnet is on this device is turn it off. So in some devices inserted, when we will put a magnet, we will not get any effect. If the magnet is effective, once we will remove the magnet from the device, most of the devices, and in most cases, the effect of the magnet will be reversed, and the device will return back to its original function before putting the magnet. But in some situations, this effect will not be spontaneously reversed by removing the magnet from the device. So these are the differences between reprogramming using a reprogramming machine or reprogramming using a magnet. This is the magnet. It is a special magnet manufactured by the company that is manufacturing the device. It is like a donut, and it has to be inserted directly on the device. We use a magnet if we know the effect of the magnet on the device, and this effect is desirable. If the patient is in supine position, because the magnet needs to be maintained in position above or on the device directly during the surgery. If the patient is in lateral position or the patient is in prone position, we may not be able to fix the magnet on the device in these positions. So the best position to use the magnet in is the supine position of the patient. And the axis and observation of the magnet must be maintained over the surgery. As a general recommendation, if we have a surgery, and this surgery is nearer to the device, the site of surgery is above the level of umbilicus, is in the head or neck, or in the upper limb until the level of the elbow. Site surgery in these areas is close to the cardiac device. If the surgeon will use diathermy, so it is better to reprogram the device before surgery. Also, if we have a surgery that we need to obtain any movement during the surgery, and this patient has ICD, as we said, we have to deactivate the ICD function of the defibrillation function of the ICD, like what we said in the intraocular surgery. And also, any device has a rate responsiveness. This rate responsiveness function has to be deactivated during the period of surgery. These are the recommendations or the guidelines of the British Heart Rhythm Society, last updated in 2019, they classified the surgery above the level of umbilicus and below the level of the umbilicus. If the surgery is below the level of umbilicus and or in the lower limbs or in the upper limbs distal to the elbow, and patient have a pacemaker, in these kinds of surgeries, we don't have to reprogram the pacemaker before surgery. But if the patient has ICD, defibrillator, we have to deactivate the defibrillation function during surgery. If the surgery is above the level of umbilicus or in the upper limbs until the elbow or in the head and neck, and the surgeon will depend on the cautery machine. So if the patient have a pacemaker, it is better to reprogram the pacemaker before surgery and also to activate the defibrillation function of the ICD before surgery. Now we will go to the intraoperative management. There are 3 areas of interest during surgery. The first is how to monitor this patient. Second is how to decrease the effect of the electromagnetic interference on the devices. And the third, how to deal with the emergency complication that may happen during the surgery. First, for monitoring, we know that the ECG waves will disappear once the surgeon will use the cautery machine, and it will be replaced by the interference waves of the cautery machine. It is called Bovie waves. So we have no electrical activity monitoring from the ECG during the use of diastole. How we know that the heart is still pumping and still functioning and the pacemaker is working during the period during which the surgeon is using the diastole? We have to have another tool to monitor the pumping and the activity of the heart during this time. We have to have the wave from the pulse oximeter, and we have better to have the wave from the invasive blood pressure wave. So this, for any patient who have electric cardiac device, it's better to insert arterial line and to monitor the blood pressure invasively. This will give an idea about the cardiac output during the periods when the surgeon is using the diastole and when we don't have any ECG tracing. Regarding the electromagnetic interference, if the surgeon will use cautery, we will advise the surgeon to use bipolar if possible, and to decrease the dependence on the monopolar. But as we know, the most common mode of the diastole used during surgery is a monopolar, either cutting or coagulation mode. So during using of this monopolar, we will advise the surgeon to use the lowest possible energy level, because increasing the energy level of the monopolar cautery, it will produce stronger and stronger electromagnetic field that will affect the device more and more. Also, we will advise the surgeon to use short bursts of cauterization. He will use the cautery for few seconds, less than 5 seconds each time, and then stop using the cautery. Why? Because if the patient has an ICD, the ICD takes around 5 seconds to identify these electromagnetic waves as it is ventricular dysrhythmia. And then after these 5 seconds, the ICD will start to deliver the shock. So we will advise the surgeon to use the cautery for 2 or 3 seconds each time and stop. During these 2 or 3 seconds, there will be no defibrillation shock emitted from the ICD. Also, if the patient has a pacemaker, and this pacemaker is inhibited by the cautery, if the pacemaker is inhibited for 2 or 3 seconds, it will not do much deleterious effect on the hemodynamics and on the tissue perfusion compared to if the pacing will stop for 20 or 30 seconds. So this is the rationale behind the use of the diastema for very short burst each time, less than 5 seconds, and the lowest energy possible. Also, the dispersive electrode. The dispersive electrode, which is the X-ing pad of the diastema, we have to attach it to the lower half of the body of the patient. So the current, electric current will pass from the site of the diastema to this dispersive electrode in the lower half of the body, and the pathway is away from the cardiac device. So the current will not produce damage or will not affect the cardiac device. We have to be ready for any serious emergencies developed during the surgery. We are worried from 2 main complications. Either the pacemaker will stop pacing, so we need to be ready with an external pacemaker, transcutaneous pacemaker, or the patient will develop VF or VTAC, so we need to be ready by external defibrillator. So in any patient having cardiac device, we have to attach the pacing defibrillator pads to the chest wall of the patient from before the surgery, and to keep it attached on the patient until the patient goes postoperatively to the recovery or to the ICU, and the CIED team comes and investigate and examine the device and confirm that the device returned to its normal function. Now we can remove the defibrillation pacing pads from the chest wall of the patient, and we can send the patient now to the ward. Before this, we have to keep the patient monitored either in the ICU or in the recovery, and we have to keep the pacing defibrillation pads attached to the chest wall of the patient. The precaution during attachment of these pads is we have to avoid putting the defibrillation pads on the device. So we can put it in anterolateral position like that, or in anteroposterior position away from the device. What we can do if we will face a patient coming in the emergency for an emergency procedure, and he has a pacemaker or cardiac device, ICD, pacemaker, or CRT. We are lucky enough if there is still time to assess and to prepare this patient and to follow all the steps we said during the preparation of this patient for elective cases. But sometimes the situation is so urgent. Patient has perforated gut or patient have internal hemorrhage, and no time to follow all these steps and all these measures pre-operatively. And we have the patient, and we need to shift the patient to the surgery either now or within maximum 1 hour. So what we will do in this situation? First of all, we have to depend on the history and physical examination. We have to get as much as we can information about the device from the patient, and we will examine the chest wall of the patient and see the scar of insertion of the device to know where is the device is inserted or implanted. And even if we have a short period of time, we can call the CIED team or the manufacturer company if we have the contact information of the company, and we can get from them a lot of information about this device. Even if they cannot come and to do reprogramming of the device, they can give us an advice how to deal with this device for this emergency procedure. As we said, ECG and chest X-ray, we can differentiate between the different kinds of CIEDs. Through the chest X-ray, we can identify whether the patient has pacemaker or ICD or CRT. Also, the mode and the type of pacing can be identified by the chest X-ray, whether it is atrial, ventricular, dual pacing. Patient is totally dependent on the pacemaker, or this is a demand pacing. So this information we can get from the chest X-ray and the ECG. After monitoring, if we have a magnet, we can test. We can examine the effect of the magnet on this device. After we insert the ECG and the pulse oximetry and the invasive blood pressure, we can put this magnet, the medical magnet, we can put it on the device, and we can see the effect of the magnet on this device. Because as we said, not all devices will respond to the magnet. Sometimes the response of the device to the magnet is turning it off. So when we will put the magnet, it will lead to no effect at all. And sometimes the magnet will produce asynchronous pacing, but at a very low rate, which is not suitable. This, for example, if the asynchronous pacing rate is 50, and this 50 pacing rate produces a very low blood pressure in this patient, so it will not be suitable to put the magnet. And the asynchronous rate does not depend on the setting of the device in the asynchronous mode only. Sometimes the battery of the device is about to be exhausted and consumed. So even if the preset pacing rate during the asynchronous mode of the device is 80, due to the weak battery, the pacemaker can pace the heart at a lower rate, 50 or 55, for example. So we have to examine the effect of the magnet on this device after monitoring and before start of the procedure. We have to follow the proper monitoring, as we said. We have to apply the transcutaneous pacing defibrillation pads on the chest wall and keep it during surgery and in the postoperative period. We have to put the dispersive pad of the diathermy in the lower half of the body, and we have to instruct the surgeon to use monopolar in a very short burst and at the lowest energy level possible. We have to tell the surgeon if he can use bipolar better than to use monopolar. If he has some tools to be used like harmonic ultrasound, harmonic machine instead of the diathermy, it will be better and safer. And we have to be ready for dealing with emergency. If the patient will develop complete heart block due to absence pacing of the device, we have to be ready with the external pacemaker. If we have, if the patient develop ventricular tachycardia or ventricular fibrillation, we have to be ready with the defibrillator to shock the heart. After the surgery, we have to shift the patient to a monitored area. And we have to keep the patient in the monitored area until the team of the CIED come and examine the device and confirm that this device returned back to its normal function. In the postoperative management, as we said, patient has to be monitored. The defibrillator and pacing electrodes has to be attached to the patient until the patient is examined by the CIED and until the patient, they confirm that the device returned back to its normal function. Now, after getting confirmation from the CIED team that the device is working normally, we can shift the patient to the ward. Before that, patient has to be kept in a monitored area, either in the recovery room or in CCU, HDU, or ICU to be monitored. Now we have a case scenario for discussion. We have this patient who is 70 years old male patient. This patient has a history of coronary artery disease and he did cabbage 20 years ago. And during the cabbage, they did the aortic valve replacement due to the presence of aortic stenosis. Post-operatively, there was persistent heart block, and they decided to put permanent pacemaker in this patient for treatment of this complete heart block. And patient have this pacemaker, and he's like living his normal life. Nowadays, this patient came with lower left pulmonary nodule, and the thoracic surgeon wants to do video-assisted thoracoscopy to excise these left lung nodules. When we interviewed this patient and revised his medical record, we found that this patient was recently examined by the cardiology and the CIED team, and they wrote that this patient has a dual pacemaker adjusted at a rate of 80 beats per minute, and the underlying heart rate, if the pacemaker will stop, the underlying heart rate will be 40 beats per minute, and the remaining battery life is 7 years. And this is the ECG of the pacemaker. It is dual pacing. There is a spike before the B, spike before the QRS. Before each complex, we find the pacing spike before B and pacing spike before the QRS complex. This means this is a dual pacing, and patient is totally dependent on the pacemaker. The anesthesiologists and cardiologists, they were happy with this knowledge, and they decided to do the surgery without reprogramming of the device. And after intubation, the anesthesiologist inserted a right radial artery catheter and monitored the invasive blood pressure in addition to as a standard monitors. And the patient was put in the right lateral, the left side is up, and the surgeon started the surgery. Once the surgeon started to use the cautery machine, there was disappearance of the ECG waves, disappearance of the pulse oximetry wave, blood pressure dropped to 68 systolic, and the ECG was replaced by interference waves from the cautery machine. What happened? Simply, this patient is pacemaker dependent, and the use of the cautery machine in the left side of the chest, beside the pacemaker or beside the device, has a very strong effect, and it will produce a very strong electromagnetic field on the machine. So this electromagnetic field inhibited the pacemaker, and patient, as we said, is pacing dependent, and the underlying heart rate was unmasked. The heart rate dropped from 80 to 38, and the blood pressure dropped down to 68. So the cardiac output is low. What is wrong until now? What is the defect in the management is that we have a pacemaker, patient is pacemaker dependent. The surgery will use the cautery machine, and the cautery machine will be very close to the pacemaker device. So we are expecting that this patient will be affected strongly by the cautery machine. So it is better for these kind of patients to reprogram the device before surgery, and which is more suitable for reprogramming of this kind of procedure. The reprogramming machine or the magnet. Of course, as we said, the magnet is not suitable for those patients who are done in any abnormal position, in the lateral position or in the prone position. And also the magnet here will be interfering with the surgical field, sterility and sterilization. So it is not the best choice to use a magnet in this patient to reprogram the device. Anyway, the anesthesiologist asked the surgeon to stop using the cautery. Once the surgeon stopped the cautery, there was a regaining of the ECG, regaining of the pulse oximetry wave, and the blood pressure returned to normal. And here the anesthesiologist asked for the magnet, and there was a magnet in OR. And he put the magnet on the device and fixed the magnet with adhesive tape to maintain the position of the magnet on the device. And then he asked the surgeon to continue the surgery. Surgeon continues the surgery. During the remaining time of the surgery, there was no unwanted event. And at the end of surgery, the anesthesiologist extubated the patient and transferred the patient to the recovery room and endorsed the patient to the recovery team and requested the recovery nurse to start the epidural analgesia to control the pain. 1 hour later, the recovery nurse called the surgeon because called the anesthesiologist because this patient has severe pain. It seems that the epidural is not functioning well and patient has severe pain. So the anesthesiologist went to the patient to examine the patient. He found that the pacemaker still pacing the rate at 100 beats per minute. I forget to tell you that the asynchronous mode, when the anesthesiologist put the magnet on the pacemaker, the rate was 100 beats per minute. And at the end of surgery, the anesthesiologist removed the magnet from the pacemaker. Suppose that once the magnet is removed, the pacing will return back to the 80 beats per minute. But he noticed that the pacemaker is pacing the heart in the recovery at a rate of 100, and there is heart rate, endogenous or native heart rate of the patient is 110. This is the effect of the sympathetic overactivity due to the pain. It induced the acceleration of the heart rate of the patient to 110. So now we have heart is beating at 110 and asynchronous pacing from the device at a rate of 100. While the anesthesiologist is examining the patient, he noticed that the patient suddenly developed VF. So what happened in this case? To understand what happened in this case, we have to go for this ECG, and we have to read about what is called R-on-T phenomena. R-on-T phenomena means that there is a depolarization wave will stimulate the myocyte during the repolarization period. We know that the QRS complex is the time of depolarization of the ventricle, and the ST wave is the time of repolarization. If any impulse stimulate the myocyte during the time of repolarization, during the period of ST or T wave, it will cause ventricular arrhythmias. If we will see here, we will find the spike of the pacemaker coming during the T wave, not before the P and not before the QRS complex. It is coming at the T wave. So the spike of the pacemaker is stimulating the myocytes during the period of repolarization, and this may induce serious ventricular arrhythmias, and it may cause polymorphic tachycardia or ventricular fibrillation. This is what happened for these patients. So this is an example that we have to maintain the defibrillator pacing electrodes and to keep the patient monitored during the post-operative period until the device is examined by the CIAD team and they confirm that the device returned to its normal function. In this case, by removing the magnet, the device does not return to its synchronous pacing rate at rate of 80 beats per minute. It remained in asynchronous pacing at 100 beats per minute. Why? Because it may be due to the strong electromagnetic field beside the device. It affected the function of the device, and it prevented the device from returning back to the synchronous mode after removal of the magnet. So if we will use magnet, we have to confirm that the device returned back to its function. The only way for confirmation is reinterrogation of the device by the CIED team in the recovery room or in the ICU. The anesthesiologist gave defibrillation shock to the patient, and after defibrillation, the heart rate was returned and ROSC was achieved, and patient the heart was paced at a rate of 100 beats per minute, and the patient was intubated and sent to the ICU, and the cardiology team was consulted to interrogate the device. The take-home message from this situation is that we have now an increasing number of patients who have these devices, so we have to know better about these devices. In the preoperative period, we have to assess this device. We have to know what is the kind of the device. Is it a pacemaker, ICD, CRT, because the management will differ. And we have to communicate with the surgeon and the cardiologist, and to put a safe plan for management of the patient during the perioperative period, and to decide if this patient is in need for reprogramming of the device before the surgery or not, and what will be the best method to reprogram the patient, either using a reprogramming machine or magnets. Monitoring of these patients from the beginning of surgery until the end of surgery, and in the recovery, and in the ICU, until we confirm that the device returned to its normal function, has to be maintained by ECG, pulse oximetry wave, and better to insert arterial line and to monitor the blood pressure invasively in these kinds of patients. We have to be ready for any complication. And the most serious complication for this patient is either complete heart block or ventricular arrhythmias. So we have to keep the defibrillator pacing pads attached to the patient from the beginning of the procedure until the end of the procedure in the post-operative period, and as we said, until we confirm that the CIED returned back to its normal function by the CIED team. Sorry for the prolonged presentation. I hope that it was not boring. These are some references. If you need to read more and get more information, you can read these references. Thank you, and we are ready now for discussion if anyone has a question. Thank you very much.
Thank you, Dr. Mohammed, for this distinguished and outstanding lecture. Really, it is a reference in perioperative management of patients with intracardiac devices, etc. And you did it very simply, but in a very comprehensive and deep way. Thank you for your valuable time and for your valuable effort to present such lecture. الحقيقة احنا عندنا أسئلة كتير، معلش هنصدق حضرتك.
لا اتفضلي يا دكتور.
احنا عندنا سؤال recommendation if we insert CVB in the same side of ICD.
No contraindication, because the ICD mostly it is inserted in the left pectoral area, subclavicular. Rarely it is inserted in the right subclavicular area. No contraindication, provided that we have to monitor the patient with full monitoring before insertion of the CVB, because the guide wire from the CVB may stimulate the sensing electrode of the pacemaker, so it may cause, may induce arrhythmias or unindicated pacing of the patient during insertion of the CVB.
The second question from Prof. Maha Lutfi. The programming is mandatory for eye surgery, especially vitrectomy.
Especially vitrectomy. For eye surgery, we will program, if the eye surgery is, we will not use the CELMI in this patient, and the patient has only pacemaker, he has no ICD, so reprogramming is not mandatory. But if the patient has ICD, the defibrillation function of the ICD has to be stopped during the eye surgery to avoid unwanted jerky movement of the patient if the patient already developed VF or VTAC during the procedure and the ICD delivered a shock to the patient. This shock to the patient to abort the VTAC or VF will cause the patient to move suddenly, and sudden movement of the patient while the globe is open, and sometimes the ophthalmologist is using sharp instrument inside the eye, it may lead to loss of this eye. So it is mandatory for any eye surgery if the patient has ICD.
Yes. Dr. Mohammed, you mean that this patient has received the regional eye technique? Yeah. Not, of course, general anesthesia. Yes.
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 Regional anesthesia, even without the use of cautery.
Yes. Yes. Also, Maha asked about cataract surgery. The same? We have to reprogram? Yes. Yes.
Yes, the same. Yes.
Yeah. Professor Iman said, asked about the Israel and the reprogramming.
Yes. Deactivation of the ICD is recommended during as well.
Yes.
But conversion of the pacemaker from asynchronous to from synchronous to asynchronous mode can be managed without reprogramming of the pacemaker. And there is this. I will return back to the previous slide. This reference, which is from the I have to decrease this first. The British Heart Rate Society. I want to read this reference, the British Heart Rate Society guidelines. In these guidelines, they have specific recommendation for each procedure. For the procedures, general surgery, for head and neck, for dental procedure, for eye surgery, what to do with the ICD and what to do with the pacemaker. And in this reference, this society said at the end of these recommendations that these recommendations is based on expert opinions, but there is no enough data to support this recommendation. So whatever the decision that you will take, provided it is based on the discussion with the CID team, with the surgeon and the anesthesiologist, whatever is the decision, either that we will reprogram the device or not, we have to be ready for managing any emergency situation that will develop during the surgery or in the post-operative period.
Yes. We have a question from Safa Rabia. What about the MRI and reprogramming?
Most of the recent devices nowadays are MRI compatible. It is called conditional MRI, provided that they will use certain energy limit during the MRI, some specifications that we are not aware about. But for the MRI, we have time to consult the cardiologist, to contact the CIED team, to get the recommendation from them. We usually, for elective cases, we have no problem, because we have time to consult the cardiologist, to get recommendation from the CIED team, to do reprogramming or not to do reprogramming. We have time to discuss all these issues and to be ready for any complication.
We have a question from Rasha Hosni. She asked about, do dual pacemaker patient can increase his rate according to sympathetic overstimulation?
معلش again كده, I want to concentrate in the question. Can you repeat, please, Doctor?
Yeah. She asked about can the patient she asked ايوه معلش ايوه do dual pacemaker patient can increase his rate according to sympathetic overstimulation?
Yes. If we have a patient with heart block, one of the measures of the heart block is to give adrenaline infusion. So the adrenaline itself, it is increases the rate of the heart during the heart block. Sympathetic overactivity will do the same, but this is not a permanent treatment to the heart block, because we cannot maintain the patient on adrenaline all over his life. The permanent treatment is a pacemaker, but the pacemaker will pace the heart at a rate of 80, for example, or at a rate of 70. And the sympathetic overactivity, if it is very intense, it can increase the heart rate, the initial heart rate, even in the presence of the heart block, to more than that. So it can overcome the pacemaker and can increase the rate above the pacing rate of the heart block.
Yes. We have a question. What is the overdrive pacing? Overdrive pacing.
Pacing. Actually, I didn't read this expression, but I promise that I can search for this, and I can, if I find an answer, I will put it on the group.
Thank you. Thank you. I have a question about during asynchronous and patient is hemodynamically disturbed, how to manage?
During what?
During
surgery? Asynchronous pacing.
Yes.
The patient
And
is hemodynamically
disturbed. Yes. How to manage?
Yes. We will manage according to this reason behind the hemodynamic disturbance. If the patient is at asynchronous mode and the rate of pacing is low, we can consult the CIED team. They can come even intraoperatively, and they can reprogram the pacemaker to a higher mode. If this is not possible and patient is hypovolemic, we have to correct the hypovolemia. We have to use vasopressors and inotropes to stabilize the patient during these periods of hemodynamic instability.
Yes, yes. Any question from the floor?
Yes, Dr. Safa, please, can I have a question for Dr. Muhammad? Thank you so much. Dr. Muhammad, thank you for this fantastic lecture. Actually, as you said, we are facing nowadays a lot of patients. They have these devices, and we should be aware how to manage such cases. Regarding to the cooperation between the cardiologist and the anesthesiologist, when we are calling for the cardiologist for reprogramming by the machine, this should be done just immediately before the operation, or there is a room or time to be done before the operation? What is the ideal time?
Thank you, Dr. Assam, for this question.
Thank you so much.
Reprogramming should be done immediately before surgery, either in the holding area or on the operating table, or even in the ICU or any monitored area before shifting the patient to the OR. Provided that once we will do reprogramming, patient has to be monitored until the patient is shifted to the OR and received by anesthesiologist. So once we will do reprogramming, we have to monitor the patient, and patient has to be attended during this period until he is endorsed to the anesthesiologist on the operating table. Because after reprogramming to asynchronous mode, we have to observe the hemodynamics of the patient during asynchronous reprogramming. And as we said in the case scenario, the asynchronous mode by itself, there may be some complication will develop due to the asynchronous mode itself, like the R-on-T phenomena that happened for this case that we discussed at the end of the presentation. Also, if we stop the defibrillation function of the ICD during the reprogramming, if we have an ICD, we will stop the defibrillation function. Why this patient has an ICD? Because he has recurrent VTAC and VF. What happens if the patient developed during this period of reprogramming, developed the VTAC or VF before shifting the patient to the OR? So patient has to be monitored, has to be attended. The defibrillation pacing electrodes has to be attached to the patient once we did the reprogramming. And monitoring will continue until the post-operative period, until this patient will be re-examined again by the CIAD team, and they confirm that the device has returned it back to its normal function before the reprogramming or before applying the magnet on the device.
Yes, great, sir. One more question, please. I'm working most of the time in neurosurgery, and in neurosurgery, the OR is full of machines. I'm working besides the OR, beside portable CT, beside ultrasonography and MRI. And the most recent, no cases can be done in the spine surgery without neurophysiological monitoring.
Yes.
So is there any harm or any interference while we are using neurophysiological monitoring with the patient with a pacemaker, permanent pacemaker?
I don't know.
Yes.
They said that the most effective electromagnetic interference is from the coronary. And they mentioned the transcutaneous nerve stimulator as a source of electromagnetic interference. But the somatosensory evoked potential, for example, they didn't say anything on it. I didn't get interference from neurophysiological monitoring on the pacemaker.
Because you know, Dr. Muhammad, in neurophysiological monitoring, all the time, continuously, they are elaborating stimulus for the patient to monitor the sensory and the motor effect of on the patient. So really, I didn't read about this, but I hope somebody or who are attending or you, if you search about the relationship between the permanent pacemaker or ICD and the effect on the use of neurophysiological monitoring and so on. You will be
the simulation during the neurophysiological monitoring, either sensory or motor stimulation. The stimulus usually is away from the site of the pacemaker. Stimulus usually is in the hand, in the lower limbs, away from the site of the pacemaker.
Yes.
I believe, or I think that it will not produce a lot of interference to the function of pacemaker, but we have to look for a source or a reference mention this knowledge and information. I will look for it, and if I find something like that, I will put it on the group, inshallah.
Please, sir. Thank you. By the way, this is my last question. Is there any recommended distance between the diathermy and the site of the pacing or machine?
Yes.
Recommended distance? Yes.
Yes. It is most powerful. The most powerful effect of the diathermy is within 15 centimeters away from the device. If we use the diathermy within 15 centimeter distance to the device, the effect of the diathermy will be very strong on the device.
Yes. Thank you so much, Dr. Muhammad. Thank you.
You're welcome, Dr.
Thank you,
Thank
Dr.
you for
Assam.
your...
Thank you.
Thank you.
May be the idea of neurophysiological monitoring will be idea for new research for one of our new generation, maybe.
Inshallah.
Inshallah. We have a question about the patient under spinal anesthesia or nerve block, and we should have invasive monitoring for such a patient. Even he is under regional or spinal anesthesia, we should do invasive monitoring.
Invasive monitoring. If we will use the diathermy in the upper half of the body, so the use of the diathermy will affect the pacing of the device, and the ECG will disappear. We have to have at least we have to have the wave of the pulse oximetry to know that the heart is still working during the period of use of the diathermy. If we can insert the invasive arterial line and we have two monitors to monitor the cardiac function during the period of the use of the diathermy, it will be more safe and more better. Because you know, Dr. That sometimes the diathermy is not sensing well, the pulse oximeter is not sensing well if the periphery of the patient is cold. So we find that the pulse oximetry is not reading, the wave is not clear if the peripheral perfusion is impaired. So if we will depend only on the waves of the diathermy, it's usually we see this situation that the wave disappears and the reading is affected by the peripheral perfusion.
Yes. So sorry, we have another question. It is important. Thank you. It's important to know underlying rate and risk pre-operative and how to do such thing in emergency.
I couldn't understand the question.
Ahmed, if Ahmed Hassan is present, he can ask his question by himself. Unmute yourself and ask. Ahmed?
Is it important to know underlying rate and risk pre-operative and how to do such thing in emergency? Yes. We will not be able to know the underlying rate and risk except by the searching through the medical record or through the device card, because we cannot stop the pacing of the pacemaker to know the underlying rate and risk. This can be done in the electrophysiology clinic. They can do this, but we don't have the tool to stop the pacemaker. all what we can do to put a magnet and to see the response of the magnet. And usually when we put the magnet on the pacemaker, it will convert the mode of pacing from synchronous to asynchronous. And the rate in asynchronous mode, it depends on the manufacturer settings and the setting done to the device during insertion of the device by the CIED team. And sometimes even the rate of asynchronous mode is affected by the battery life. If the battery is weak, the rate of asynchronous mode is lesser than and lower than the presetted rate of pacing during this asynchronous mode. But to stop completely the pacemaker in order to check the underlying rate and rhythm cannot be done in OR by the anesthesiologist. Yes. It has to be done by the reprogramming machine by the CIED team.
Anyone have a question more? Anyone have a question more? Now everything is clear for you all. تمام. سؤال، مش هتلاقوا فرصة زي دي تاني.
لا ان شاء الله يلاقوا باذن الله فرصه زي دي واحسن.
لا 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 بجد ما شاء الله ما شاء الله ما شاء الله.
Just technical question دكتورة صفاء. دكتور محمد. دكتور محمد, is it our job as intensivists to insert the permanent pacemaker?
Permanent pacemaker?
Yes.
No.
As intensivist, not anesthesiologist.
According to the what I know from the program of the intensivists in the ICU, they don't have this privilege to insert permanent pacemaker. Permanent pacemaker is inserted in the electrophysiological cardiac lab, not in the ICU and not in the ward. So it is inserted by the electrophysiology cardiologist, and the team of the CIED of the pacemaker from the company manufacturing the pacemaker, they must be available, and they have the reprogramming machine to adjust the setting of the permanent pacemaker. But I think of course, the transcutaneous pacing, we have to know how to pace the heart transcutaneously, and also it may be a privilege for the ICU to insert the transvenous pacemakers. These are kinds of temporary pacing.
Yes.
But the permanent pacemaker, it is the job of the cardiologist.
Yes. Yes. Thank you.
Yeah, welcome. Thank you, Doctor.
Anyone have a question? Anyone have a comment? شكرا لحضرتك يا دكتور محمد، شكرا لوقت حضرتك وجزاكم الله خيرا عنا كلنا يا رب، وربنا يزيد
الله يخليك يا دكتور صفاء. انا اللي شاكر لحضرتك ان حضرتك اتحتي لي الفرصه دهيت. ربنا يكرم حضرتك ويجزيكي خير ويجعل كل ده في ميزان حسنات حضرتك، يا رب يكون بفايده زمايلنا كلهم يا رب.
يعني ما شاء الله حضرتك الكومنتس زي ما انت حضرتك شايف كده يعني، فربنا يجعل كل ده كثقل جبل احد في ميزان حسنات حضرتك ان شاء الله واكتر يا رب، اللهم امين. وربنا يتقبل حضرتك يا رب. لا والله كتر خيرك، كتر خيرك على كل حاجه. انا في حاجات على لساني عايزه اقولها بس مش راضيه بصراحه يعني.
الله يخليك يا دكتور.
ربنا يكرمك، وحضرتك عارف انا مش راضيه اقول ليه يعني.
لا لازم تقولي. لا 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 لازم تقولي
يعني يا دكتور عصام، دكتور محمد لا يدخر وقتا ولا جهدا ولا مالا في سبيل دعم. فانا بأحييه يعني، مش عايزه اقول لك هو كان محلفني ان ما اقولش يعني كده، لكن انا ما اقدرش. ربنا يجازيه عنا خيرا يا رب، اللهم امين. في جهد وفي وقت.
انا اسمحي لي يا دكتوره صفاء ان انا اقول برضو كلمتين للدكتور محمد بالنيابه عن الجروب وبالنيابه عن حضرتك. حضرتك من الناس المحترمين جدا، العظماء جدا،
الله يخليك يا دكتور صفاء،
العلماء
ده من ذوق
جدا.
حضرتك بس، ربنا يكرمك.
واحنا كلنا بنشكر حضرتك على مجهودك وعلى علمك، وربنا يجازيك عنا كل خير. وانا لسه قبل ما نخش على الجروب كنت بقول للدكتوره صفاء ان كل الزملاء وخاصه الجونيورز لازم تو ابريشيت الايفورت اللي بيحصل على الجروب، وخاصه للناس المحترمه جدا العلماء امثال حضرتك. فالف الف شكر يا دكتور محمد على وقت حضرتك.
العفو يا دكتور،
وربنا يجازيك خير.
شكرا جزيلا.
وبنشرف بحضرتك وبمعلومات حضرتك وبنتعلم من سيادتك كل مره.
العفو،
حاجات جديده. الف شكر.
يعني حتى طريقه الالقاء بصراحه يا دكتور محمد، انا قاعده اريفايز في دماغي ازاي انا لازم اتكلم زي حضرتك كده، وازاي ارتبها كده، وازاي ابقى هاديه كده. ان شاء الله
ربنا يخليك.
ان شاء الله ربنا يكرمك ميزان حسناتك. متشكره لحضرتك طبعا يا دكتوره عصام، يعني الله يكرمك يا رب ويعزك، كتر خيرك. بشكركم جميعا، وان شاء الله الى لقاء قريب قادم حضرتك يا دكتور محمد ان شاء الله باذن الله. واحب انوه ان احنا ان شاء الله الاسبوع الجاي باذن الله احنا عاملين بس في يوليو كوندنسد كورسز، علشان احنا عندنا في اغسطس شويه ارتباطات علميه برضو، بس هتكون ممكن تبقى خارج مصر في اغسطس، عشان كده احنا عمالين نسرع في عدد المحاضرات في يوليو يعني. فان شاء الله عندنا محاضره رائعه وجميله من بروفيسور محمد امين. دكتور محمد امين بروفيسور في القصر العيني، وعنده موضوع جميل جدا اللي هو الامباكت اند تشالنجز ان امبلمنتيشن اوف ذا تيلي اي سي يو ان ايجيبت. طبعا التيلي ميديسن ده كان لسه بيظهر ايام الكوفيد والارتفيشال انتليجنس والكلام ده، لكن الحقيقه يا دكتور محمد انا من رايي ان الارتفيشال انتليجنس والماشين ليرنينج ديت a way of thinking، منها اكتر منها ماشين وكده، لان لما بتحط للبرنامج انبوت ان العيان ده اوبيز والعيان ده دايابيتيك وهايبرتنسف، يو كان سسبكت اند بريدكت دي ميس هابز او الميس ايفنت اللي ممكن اللي ممكن تحصل انترا اوبراتيف. يعني هي طريقه تفكير، وخاصه ان احنا كمان بقى عندنا في مصر مثلا اكتر من 5 كليات ذكاء اصطناعي، ربنا يكرم ان شاء الله ويبقى فيه كالوبريشن بين كليات الطب والذكاء الاصطناعي، فتقلل الهيوج انفورميشن على مخ دكتور التخدير شويه وعلى مخ كل الناس اللي بتشتغل في الميديكال فيلد، ويبدا في الارتفيشال انتليجنس موجود معانا في الاو ار، فيخفف عننا وعن طريقه تفكيرنا شويه. انا بشكركم جميعا كل الشكر والتقدير والاحترام لحضرتك يا دكتور محمد، ربنا يخلفه عليك بركه في المال والاهل والولد، وشكرا لحضرتك، شكرا جزيلا. شكرا لكم جميعا ان شاء الله، ومنتظركم السبت القادم الساعه 8 بتوقيت القاهره. السلام عليكم.
ان شاء الله. عليكم السلام ورحمه الله.
السلام عليكم.
عليكم السلام.